hitting AI companion. And does it say it's recording on your end? Can you see it? Okay.
No, it just says AI companions on.
Oh, can you not do both? Oh, it's recording. Okay. Oh, hey, Chris.
Hey Chuck, how are you?
I'm great. I'm great. It's fun to be back.
Yeah, it's a nice, warm-ish Saturday morning in St. Louis. It was not warm enough for my windshield not to frost over this morning, but so that may be a little bit delayed. But it's going to be 60 degrees Fahrenheit here tomorrow, I believe. The tennis courts are open. I got some emails for 2 days, so that'll be fun.
Well, we need 60 because we still have snow from a month ago. How long is it? And 3 weeks ago?
The old St. Louis strategy of just hope it gets warm enough for everything to melt.
That's
Yes.
my strategy.
Uh-huh. Uh-huh.
We can share some advice, which we got from a really concerned listener on that front. But I feel like first I should apologize for those who have chosen to tune in on YouTube for my disfigurement.
Who beat you up, man?
I know it's exactly what it looks like. I had a small lesion removed over my eye. I now have a black eye. It's been a couple of days, but I was under local only anesthesia for about an hour, which it was good for me to see. It's a lot.
What the hell do you talk about for an hour under local review? You just shut up and let the surgeon do their thing.
Oh, it's funny you say that because we had a good conversation, but occasionally things got quiet on the other end, and I was like, and then I would say, "Everything okay up there?"
Are you draped out? Like, how do they drape out above your eye? Like, I don't remember any of these things from whatever my plastic surgery rotation was.
Yeah, it was just a little like a sheet with a hole cut out and a little tent for me to breathe, and yeah, it was actually totally fine. But an hour's a long time. Note
An
to
hour.
self.
Yeah, no, I've done some tendon transfers and tenolysis under local that have been the better part of an hour, and you just kind of run out of stuff to talk about. I can gab with the best of them for a solid 10, 15 minutes while I'm doing a carpal or a trigger or multiple triggers, something like that. And I love it when you have the chatty nurse up top, but I mean, it's a lot. So I'm glad you're doing well. At first, I was very concerned. I didn't know leadership was that hard, but
Yeah, I said the wrong thing to the wrong person. And then the other thing, given that we still have ice, is I've gotten 50 questions about slipping on ice. And I'm like, I don't know
right.
how it would do to the eye, maybe the wrist, but I'm
Right.
good.
I've actually, I don't know if it's a factor of kind of how my clinics have fallen, but I've treated less ice-related distal radius fractures by far compared to last year. I think I've only done a couple as opposed to the bolus of whatever was 9 in 3 days I did last year.
Yeah, I think it's probably because people simply can't get into your practice. I mean, it's a good thing and it's an interesting thing. I kind of wanted a few more. I've had a couple, but not that
Yeah,
many.
we are now back to hearing it took 6 to 8 or 2 to 3 months to get in to see you, unfortunately. So
Good problem, but still a problem.
yes. So we should share our fun listener tip, actually a viewer tip, because it was on YouTube about ice. And this is a very kind comment on the LRTI episode from Nancy Beeman, 428. So first gentleman from a New Englander, no salt. It's not needed. Salt is bad for the environment, your dog's feet. You don't want to track it into the house. Just shovel. If the storm brings a lot of snow, shovel in stages before it gets too deep. If it is going to be followed by freezing rain, wait till the storm is done. Then, okay, so we can talk about that in a second. She's the second I'm a hand therapist for 25 years. In my experience, mini tightrope CMC does very well in the early weeks post-op, little to no pain and great range of motion. However, pain increases around the 6 week mark and pain and patients struggle. Where LRTI has pain in the beginning and improves with time. I've seen many tightropes used as revisions, and those patients do quite well, perhaps best used for that purpose. By the way, I never let my patients call their small finger a pinky.
Nancy is full of sage wisdom.
So much to talk about in that.
I love it. Well, the
So
ice we should talk about first. There's no way in hell I'm shoveling in stages. We just don't get that much.
So I shoveled in stages to the point where I actually broke my shovel. And then I had to get a new shovel. But then when I went and reshoveled, the driveway looked pristine. And I was so proud to have like a pristine driveway, like all the way across, all the way up and down, for the entire time in the weeks after the storm, because none of the stuff surrounding melted. So that was out of precaution, mainly because I did slide down my driveway last year,
Yeah, you do have a
holding
little,
coffee. Coffee did
but
not spill.
But you have
I have a hill.
a hill, so
I
you
have a
got to
little
do
bit of an
something.
incline. So
It is
it was self-preservation.
yeah, well, good for you. I'm sure your neighbors were jealous. My driveway is flat. I eventually had to shovel a path for the front door and for the trash area, but no shoveling for me.
So how do you feel about the her take on how patients with tightrope versus LRTI do in terms of when they have their discomfort?
I think it's spot on, honestly. Well, first of all, I use the mini tightrope as a salvage procedure for a failed LR, not really salvage, but for a revision procedure for LRTI or for internal brace. And I do love it for that. I think it's the best option for that. I don't use it primarily, although I have. But I think the LRTI comment is really the most important part is it's a little slower to hit the mark. But I still like LRTI. I still call it the gold standard.
Yeah, so I think we talked about this last time. How many LRTIs do you think you do a year?
Not many. And I was just talking to one of our fellows about that. That I think my goal is going to be not that I see that many patients that need this operation. It's maybe two or three a month nowadays. But I want to do maybe one a month should be my goal.
I think mine's gonna be one every fellow rotation.
Maybe
If we
that.
could work that out. But yeah.
Maybe that. Yeah.
Um, s-
It's like open Dupuytren's. You know, you know, you want to do the right thing, of course, by the patient, but we don't want skill sets to disappear because people aren't learning in their fellowship.
right. I think that's fair. I mean, I think that you're as a trainee or a learner, as we say now, I think you're pretty vulnerable just to the randomness of somebody's practice. I think a lot of us have some consistency, but everybody knows that stuff comes in waves, right? So, you're going to have waves of certain surgeries, and if it happens to fall in your rotation, great. But there's not much you can do about that, to be honest with you.
No, I think that's exactly right. And our job is to try to the best of our ability to make sure that through the ups and downs, we end up with a broad exposure, which I think we do because we're blessed with plenty of volume.
Yeah, no, you got a pretty broad exposure here, and I think that well, fellowship interviews coming up. Probably could talk about that during an upcoming episode. But yeah, no, I look through all of our numbers and what our fellows do every month, and it's pretty incredible what they get to see here. So yeah, there's no really area of hand surgery that's uncovered here. So before we jump forward, we got a great email from a listener and one of our former residents who's currently in practice. We should talk about our sponsor. So the Upper Hand is sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource.
Becoming a physician is hard. Finding the right job doesn't have to be. Join PracticeLink for free today at www.practicelink.com/the upper hand. And I will say that we interviewed someone who found us on PracticeLink, which
Oh,
I
great.
thought that was super interesting and made me sort of proud.
There you go.
Didn't end up working out, but it was a great candidate.
All right. So I'm glad that you put the job up on PracticeLink.
Absolutely. I didn't make that decision, but it was up. It was up.
That's
Yes.
awesome. So I think we do have a topic for later on, but we have a follow-up question about our amazing series with Sanj Kakar, who I did see at the combined meeting recently and was looking good in the Hawaii sun and is very happy to be a podcast guest. But this is from Nish Javedi, who was a former resident here at WashU and went on to train in Seattle for his hand fellowship, a great hand fellowship, and is now in private practice in Minneapolis at Twin Cities Orthopedics. So he's been listening, I think, since he was in training, and I'm glad that he continues to listen. He had a question that came to mind, and I'd like to pose it to you, Chuck, if that's okay. Mainly your algorithm for foveal tears in a setting of ulnar positive variance and ulnar impaction. So he goes on to state a patient who is young in his 40s, so we'll say young, with manual laborer with ulnar-sided wrist pain for 9 months, refractory to conservative treatment. So positive ulnar variance, 3 to 4 millimeters, no cystic changes. Tender over the fovea, pain with ulnar impaction, a painful click with mild laxity of the DREJ when shucking in neutral, but no gross instability. MR arthrogram shows a complex TFCC tear with likely foveal involvement. Primary complaint is pain and denies any feelings of gross instability. So how do you think about this patient? And Nish has a couple of very pointed questions, but would love to hear how you approach this as the wrist pain guru.
Yeah, I don't know about that, but I'll take a stab at it. First of all, I would say that gross instability is rare. Um, and I think our ability to detect less than gross instability is not good. So while I don't want to say it's either unstable or not, because I do think gradations matter, and as I've said before to you, I'm trying to solve that issue with using technology, but I'm not there yet. But instability matters, variance matters, and pain matters. And to me, I would approach this like I would approach an adolescent. Lindley Wall and I have a high volume, and honestly, we need to share our strategies and our results in this adolescent population, adolescent slash young adult population, because we feel super strongly that those patients should be shortened, formally shortened, in addition to addressing the TFCC. But if you're going to address the TFCC, I think you should address the TFCC. So debridement to me doesn't make a whole lot of sense in a young 40-year-old or ish. So I would do a foveal repair if you find what you think you're going to find, and I would do an ulnar shortening osteotomy. Do you agree or disagree?
I agree. I'm curious, the role of shortening only, because I think we had a listener who emailed a couple of papers to us, and we talked about that briefly on an episode a few months ago. But I think in somebody, if the ages were shifted, if this was patient 2 decades older, I would think much more of shortening alone and a debridement, plus minus an arthroscopic debridement. I'm curious so I think I would agree. I would debride, foveal repair, and shorten. Um, Lindley brought up an interesting point one time in conference about whether the sequence in which you do it. Do you shorten first and then scope, or do you scope and then shorten?
I typically, so Lindley feels strongly shorten first and makes your scope easier. I don't disagree with that, but I typically scope first, unless we're in a situation with someone who's like a centimeter positive. And I still think it's not a hard scope, but what becomes more challenging is sort of visualizing ulnarly, like and doing the hook test. So it's a little trickier. Honestly, I don't think it matters, and it's a reasonable argument. If I scope first and do the repair of the TFCC, a foveal repair, I place my sutures, but I do not stabilize my sutures until I've done the shortening.
Got it. That's a really important point. Um, you know, I, I've I tried it the way that Dr. Wall prefers one time, and I found that at least for me, the OR that I work in is so amped up about the wrist scope, they actually kind of want to get that done first. Because they've got everything set up, they're all ready to go, and we do more shortening osteotomies. That's more routine, more in their wheelhouse. The wrist scope is just enough out of their normal routine where they want to get that part done. That was my sense in the room because like, why are you doing this other part first? Because I'd done it the other way for so many other times.
Yeah, I think it's well said. W one thing we should do probably is have a guest on, and I don't want to lock us in, but I think Warren Hammett would be a good guest to talk about metaphyseal shortening. I continue to be intrigued by that technique. I don't know if you've ever done it. I always do the standard plate. I think it's a great operation. It's sort of like why mess with it, but the results are pretty good with less hardware and less invasive metaphyseal shortening.
Yeah, no, I think Warren would be a great guest, and I think that'd be a very interesting topic. I always wonder, I fall back to using the standard plate that many of us use, and I think it's too big, especially if you're doing this in adolescents and young adults. And I've tried using a different system with a smaller plate, but the system part of it was not as good. Plate was great, but the system was not as good.
Yeah, yeah, totally agree. So I think we agree we would sort of do it all because ultimately what we want for this patient is not multiple surgeries and doing just the scope and repair or just the shortening, I think really carries a risk that you'll be back. And I think in 2025, we don't want that. I think back when I was training, light years ago, I think it was seemingly more acceptable to do things in stages. And I just don't think we do that much anymore.
Is that when they had VCRs as the Riscope tower? Because I remember you showing in your talk, there's literally a VCR in your illustration of how to set up a Riscope.
There definitely have been VCRs in my life in surgery. So yes, and most people don't even know what a freaking VCR is, but it was the old cassette tape. Again, how do you describe it when you can't use modern terms?
They don't know about the Betamax. These kids, like they just, laser discs, like they have no idea what a CD is. I mean.
Well, so much history is being lost. I encourage
Hmm.
everyone to Google it.
So before we get into the meat of our episode, I wanted to mention that Checkpoint Surgical is continuing to expand their biomaterial portfolio with the launch of ACM Shield Soft Tissue Barrier. ACM Shield is a dehydrated placental membrane allograft for use as a protective barrier in surgical applications.
Comprised of the complete, intact layers of amniotic tissue and minimally processed to preserve the native structure of the tissue. ACM Shield is an ideal protective barrier and extracellular matrix scaffold for use in a variety of surgical applications such as nerve and tendon repair. To learn more, visit checkpointsurgical.com. The copy doesn't have driving innovation in nerve surgery. Is that the
Look at that. You're
tagline?
just giving them free advertising now. You're just giving them extra copy. They really tested your enunciation and your voiceover skills. I keep seeing the voiceover ads at the Clayton podcast studio on Big Bend. I might have to stop by. I mean, we my son had a hockey tournament in Wisconsin last weekend, and it
Whoa.
was amazing. They actually had a PA announcer for the
Oh, wow.
10U hockey games. So it was really cool. And I was like, I'm just going to add that to my list of retirement gigs. I'll announce youth hockey games.
So both are amazing. The fact that you traveled to Wisconsin with your
Oh, it was
10-year
it was a
old.
whole thing, man.
Is it one trip a year? Like, is that because I think
Yeah, they
that
have
is,
they have one out of town at this level, just one out of town tournament a season.
yeah, that's cool.
Now the kids had a good time. I mean, it's not somewhere and this is not against anything against Wisconsin, but this particular area of Wisconsin is not somewhere I would have particularly picked to go. But an indoor water park in February is awesome.
Oh, I miss those days.
They loved it. They loved it. The kids had a great time. The boys played very well. It was very hard to watch them lose in a championship game to a very good team from Minnesota that I'm pretty sure was playing down to build confidence.
Oh, youth sports.
Yeah, exactly.
Gotta
Yeah.
love them. All right.
So yeah, I wanted to talk a little bit about we I think we briefly touched on this FPL reconstruction. I think it's come up quite a bit more, I think, in the setting of volar locking plates. And I think everybody's very mindful of how we position our plates now to minimize the chances of this issue happening, but it does happen. And we're seeing just a number of them here. And I think, pretty much they were coming up in patients that had been fixed elsewhere and had this issue come up. And then I started asking around with you and Ryan and some of our partners of who else has treated these, because I had a run of them. Like we said, everything comes in waves. And I had been going to doing a FPL reconstruction using an interposed autograft, either their palmaris or a hemislip of FCR or a full FCR and weaving it in. And then I've learned that you and Ryan had some cases where you either did that or you had done a tendon transfer. So can you talk to me a little bit about your thought process on, aside from counseling them about, we have to do the surgery, et cetera, or you don't have to do surgery actually, um, how you talk to them when this comes up?
Yeah, maybe briefly go back to kind of why and if and when to counsel patients, if that's okay. I
Hmm.
think we agree that if we have to plate the distal radius more distally than we would prefer, I start the conversation at the first postoperative visit or in the recovery room saying we may have to remove your plate or at least keep a close eye on things. And I think most of the hand surgeon community who do this kind of surgery regularly probably see that the same way. It's just that not all FPL ruptures are could we so clearly predict. What's your sense on when you have an FPL rupture? Could you look at the X-ray and say, of course this was going to rupture, or is it just not so clear?
Well, it's confirmation bias, right? I think that you nitpick, especially if it's somebody else's X-ray. I think we all do that. Like, if it's different, if it's your own X-ray, it's just like any complication. So I think we nitpick. We look at, oh, well, this wasn't perfectly reduced. Clearly, the plate's a little distal. It's prominent. Or they chose a thick plate, or that screw was sitting up. So yeah, I mean, I think you nitpick the X-rays. I think if it's done anatomically and the plate is sitting appropriately, then it's probably not going to happen. Um, and interestingly enough, when we wrote up a case series, this is kind of the end of the story. The median time from fixation to FPL rupture was 6 years. So this can happen down the line. And I know there are case reports out of Japan of it happening 13 years later. So, And the reason we started to look at this is that there weren't many series about actual results after reconstruction. But yes, to backpedal to our conversation, I do think that you try to keep a close eye on it. You have to remind yourself in all of your dictations that you're keeping a close eye on it. And sometimes the patients will remind you, but sometimes they'll forget. I had a question for you about that. So if you put the plate more distally than ideal, do you do anything different with your pronator quadratus? Because I think the PQ management is in the literature has not been demonstrated to make a huge difference, but I think some hand surgeons feel strongly about it, that it's a very hand weenie kind of thing to worry about. But do you reapproximate your PQ certain situations all the time?
Yeah, two comments, of course, on that. First is, and just technically for younger listeners, w- it is okay to reduce the radius so that the tilt is neutral, right? We all know that a neutral tilt is satisfactory, but a neutral tilt is not what these plates are designed for. These plates are designed for a volar tilt of 9 degrees or whatever. So if you have neutral, the plate's more prominent. So that's part one. Part two is the PQ, the peroneal quadratus, does not go distally enough, as you know, to cover the plate. And so the problem, in all likelihood, is the distal row or the distal aspect of the plate. And if your plate's distal, it's not covered by the PQ. So I do tend to put a stitch or two in the PQ if I can. And I would say 70% of the time I can. I don't have great faith in it, but when I've gone back on my own patients, it's reestablished, but it's not covering the whole plate.
Do you think that you can advance part of the PQ enough to rotate it over to cover the distal aspect of the plate?
I do not, but I maybe I need to be educated on that. I do not.
Yeah, I've heard some people talk about that. I mean, I think that the PQ, it's obviously traumatized typically, and it's not easy to sew into that meat, to be honest. And I think the what I learned from when I was in residency, I like the way that Scott Wolf did it when he was big on repairing the PQ. He took the brachioradialis and split it longitudinally as he was releasing it, so as to leave the BR attached to the PQ insertion on the radial aspect of the distal radius, and elevated that altogether, so that at the end of the case, if he wanted to repair it, he could repair BR with PQ to the other half longitudinal split BR, and that's just much more reliable. I don't routinely repair the PQ, and I do my absolute best to get as close to a volar tilt as we can on the reduction because I agree. And we learned this from Dr. Orbe when he came on the pod about these plates. He designed his plate to sit in an anatomic reduction as opposed to, accepting neutral. And we, again, from an orthopedic, bone perspective, it's okay to have neutral tilt, but not necessarily in the context of having a volar plate there.
Yeah, yeah, well said, well summarized. It's interesting. Uncommon things like an FPL rupture are often underrepresented in the literature, and you may not be able to find really much at all. And there's lots of examples of this, and I think that's why you led the way with a couple of things we did, and I'll put it in the show notes. One, we have a techniques article, and the other is a retrospective review. And I think it's important. This is not the kind of research that changes the world, but hopefully it's the kind of research which provides a resource for people who, like us, even though we're a busy center, we just don't see that much.
Right, and the thing that I found kind of weird was that like there's so many papers talking about this happening as a complication,
Yeah.
just like percentages, and yeah, it happens. But then there wasn't a lot to like guide you as you were trying to figure out what to do for your patient. And funny enough, after we published the technique article, former fellow podcast listener, good friend of the program, Steve Lanier, texted me a screenshot of the technique article that he found that we wrote up. So it was perfect, and I'm glad it helped somebody, right? Hopefully somebody else has found it too. Um, but I think that like again, this is not my research focus. It's not your research focus, but it's an area where I think that we have a series we can contribute. And I think that it was good that we had two different ways of doing it. So can you talk about when you would do an FDS, typically from the ring transfer versus when you would reconstruct the FPL?
Yeah, I think I have to be honest and say I don't have a line in the sand, but I'll say this. It starts with a conversation in the clinic. And for some patients, the concept of taking the ring finger FDS is problematic. But I do like the option of going to the operating room with both options on the table, so to speak. If the patient, I do prefer the palmaris over a hemislip of FCR. I just think it's easier, it's cleaner, it's more size appropriate. So that is absolutely my preference. to use that Palmaris if I'm going to do it, an interposition tendon graft. I lean towards the interposition tendon graft. I happen to do a lot of FDS transfers with the pediatric population, so it's a straightforward operation for me. Um, but I think I would just say, and I'm curious as to where you lean before we talk briefly about technique, but I lean towards interposition.
Yeah, I lean towards interposition as well. I mean, I give a talk about plexus in which I talk about the importance of grafting nerve roots because you have so many axons and you never want to leave an axon on the table. Our partner Marty Boyer, we were talking about the FPL and what to do, and he's like, "Why would you leave all that good muscle belly on the table?" So he's like, "It's like you talk about your plexus. You don't want to leave any of that, unused." And it is a very strong muscle with independent innervation. I mean, it's a great strong muscle that I do think you can interpose a tendon. Gets a little tricky in terms of, retrieving the tendon stump and transferring it over, and then usually have to open the carpal tunnel. It's not a small affair.
Yeah, it's just like FPL ruptures. When I have a patient, or FPL, more commonly FPL lacerations, we know that technically that operation is not hard, and I'd much prefer an FPL over a zone 2 FDP or FDS or both. But it's where is the tendon, and how am I going to get the tendon often from the forearm or the carpal tunnel back to do the repair? I really like to maintain the carpal tunnel being intact because I like the concept of the transverse carpal ligament serving as a pulley. But to your point, you just can't always do it. I don't repair it if I open it because I don't think you need to. But if I can leave it, I do and try to carefully pass the tendon or interposition tendon through the carpal tunnel.
I think that's really tricky. I just open it, to be honest with you, because I don't want to deal with, working on the radial side of the carpal tunnel and the nerve and the median nerve being there. That's my bias, obviously, with my practice. I think it's really hard because typically where the rupture site occurs in some of these is kind of at you got a couple of centimeters past the musculotendinous junction, but it typically is where obviously the metaphysis of the distal radius is. And by the time you clean up your tendon, you're sewing in just beyond the musculotendinous junction if you're interposing. It's what can be tricky sometimes is if the distal stump protracts into the carpal tunnel, and then you got to get it there. And then the really hard part is when it's beyond the carpal tunnel and underneath the thenars, but not quite at where you would have your A1 pulley. That's a tough area to get it at.
Yeah, and I would say that that's the most common area for me that I find it, and so that's an important issue. And I'm going back to your previous comment about where the rupture happens. The other reason to have the FDS as an option is I have seen them where there's not a lot of tendon to muscle to work with. And so, yeah, there'll always be a little tendon, but do you have enough to get a nice weave where you can really work with it? Or those are the cases sometimes I think about an FDS with.
Yeah, no, I think that's well taken. I mean, if you're doing an FDS, how do you technically harvest that in a couple of quick pearls, and then how do you inset your tendon transfer?
So when I take the FDS, I essentially make a trigger finger incision proximal to the palmodigital crease of the ring finger. You want to leave a tail of FDS behind to minimize the rare chance of hyperextension at the PIP joint. So just stay out of the finger. Um, and then I make a second incision over the carpal tunnel. And I harvest the FDS just distal to the transverse carpal ligament. And then I use the transverse carpal ligament as my pulley. So I actually pass a hemostat from deep to superficial. And then I pass my FDS up through the transverse carpal ligament, and voila, you have your pulley. And exactly where you put it, sort of midpoint on the ulnar side, mid proximal distal ulnar side. And then I pass it subcutaneously towards the thumb. Once I do that, I close my first two incisions. I find the rest of the FPL and I perform a quick weave, and that allows early motion.
Any
Um,
pearls for tensioning?
yeah, over tension, of course. I do try to use tenodesis. So with wrist flexion, your thumb should extend, and you want it to hyperextend slightly. And then with flexion, I think you're expecting it's going to be pretty tight because it does really loosen up. I'm showing those on YouTube. Maybe not quite as tight as I have it, but maybe something like that with wrist extension. So your wrist is 45 degrees extended. Your IP joint's probably at 45 degrees. And then it loosens up a bit with wrist flexion. Do you see it differently or similarly?
No, I don't see it differently. I mean, I think that in this context of the reconstruction after volar plate, I think that's exactly how I would do it in terms of tensioning. I've only done interpose, so I haven't used an FDS transfer for this, and I've been very happy with how they do. I use a dorsal blocking splint afterwards post-op, and but I will get them flexing pretty quickly because typically I have a strong weave, and I want to make sure that we maintain appropriate glide. I think that's the biggest concern that I have after these, and I've been really impressed with how they do, to be honest with you. Our case series showed an average of 30 degrees of IP flexion. I've had people go beyond that. It was interesting to have outcomes assessed, and a few people actually let us assess them, but we had to assess them over Zoom. And we actually sent them a little binder clip, which give an example of. But we used the binder clip to assess pinch strength, which was interesting. Is one way to do it. It's part of the reason why I didn't get into JHS, the regular version. But it was the best we could do to assess strength without having them come in.
It's a great trick. And you have to have the right size binder,
Yeah,
because
no.
there is a predictable pattern of how much strength. But again, small contribution, but these small contributions really can have an outsized impact in certain situations. I think this one will.
Yeah, and then just for full transparency, in our case series of 15, there was one patient who had a re-rupture. She had lupus, and then she opted not to have another surgery, although it was planned. And then there's always the option of an IP fusion. So please keep that in mind.
Yeah. Yeah. Well, this was fun. Fun to talk about a variety of topics. I think we have a couple of good ideas for upcoming podcasts.
Sounds good. I hope it's warm where you are, unless you're, in a place where you don't like it being warm, but hopefully everybody's warming up and cheering for the Chiefs in the Super Bowl.
Whoa, laying it out there. I'm pulling for the Eagles. I got the University of Alabama connection with Jalen Hurts and Smith
Uh-huh.
and many. So let's go.
It's because you got that green bruise above your eye. You're already
Well, it's
ready to
funny.
go.
As we close, I'll say the reason I was having trouble with the copy reading is I'm reading out of one eye.
You need to relax and get some rest. Enjoy your R&R this weekend, Chuck.
Have a good one.
All right, see you.